Project on the opioid epidemic and restricting direct-to-physician marketing. The opioid epidemic has been an increasing problem in our society since the 1990s, when pharmaceutical companies ramped up marketing strategies to physicians and hospital systems for opioids such as oxycodone or OxyContin. These pharmaceutical companies have been preying upon the most vulnerable population's need for pain relief and pain management by throwing excessive resources towards physicians and provider groups to help rush opioid and opioid derivatives. The question that will be addressed is whether the current policy regulating direct-to-physician marketing is substantial, or if there should be a monetary cap of $500 value for gifts received by physicians from the pharmaceutical company. Oxycodone is a semi-synthetic opioid that is derived from a natural alkaloid called thebaine, which is a precursor to most opioid drugs. Oxycodone has an increased bioavailability and half-life, which causes the analgesic effect to be prolonged. The oxycodone is also non-lipophilic, which reduces the frequency of metabolite buildup in the body and therefore is observed to have less side effects due to lower instances of toxicity. However, since oxycodone has these benefits over other pain relievers, this often leads to dependence and often abuse. Its highly addictive nature was an extreme side effect that was largely downplayed until recently by Purdue Pharma. In the 1990s, Purdue Pharma reformulated OxyContin and intensified their marketing campaign of encouraging pain management across the United States, which led to a quadruple rise in prescription opioid sales between 1999 and 2010. This led to a spike in the rate of opioid-related deaths, as seen in Figure 1. This initial rise in the opioid-related deaths is known as the first wave. The second wave of the opioid crisis refers to the shift in 2010 to heroin as the opioid of choice. Since the retail price declined rapidly and became more widely available, the heroin death toll reached 4.9 per 100,000 people in 2015. And subsequently became the leading opioid involved in drug overdose-related deaths. In 2016, the synthetic drug fentanyl became the leading cause of opioid addiction. Fentanyl is 50 times stronger than heroin and is used to treat severe pain from illnesses such as cancer. From 2015 to 2020, the rate of opioid-related deaths spiked from 10.4 to 21.4 per 100,000 people. This spike is known as the third wave. Currently, there are some legislations that have been passed in an effort to curb this epidemic, such as the Comprehensive Addiction and Recovery Act of 2016, the 21st Century Cures Act, the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients in communities Act, the Fentanyl Sanctions Act, the Blocking Deadly Fentanyl Imports Act, and the Affordable Care Act of 2010. While all of these policies attacking and attempting to regulate the opioids themselves or clean up on the back end of the problem, we as a society are allowing pharmaceutical companies to continue to promote their drugs to our most vulnerable populations. Purdue Pharma has recently been answering litigation after litigation of falsely advertising that their product name drug, OxyContin, was not as highly addictive as has been proven, among other things. Pharmaceutical companies have been allowed to run rampant in their marketing schemes for decades, and despite one of the largest companies in the U.S. coming under fire, it seems that other companies have only raced to fill the void instead of backing off. For example, in a study done by the University of Washington, it was found that after Purdue Pharma decreased its spending to promote OxyContin by 94%, its competitors increased their spending by 160% to fill the margin. The CMS database allows researchers to see which providers were targeted by this and which drugs were promoted. This is largely due to the Affordable Care Act requiring pharmaceutical companies to provide lists of all providers that have been marketed to across the country. In an article by Dr. Eisenberg and his team, they studied the difference in difference analysis of how adding different restrictions on direct-to-physician marketing can influence opioid prescribing to Medicare Part D participants. The study's results suggested that the more restrictions that an academic medical facility puts in place, the less opioids that were prescribed. As shown in Figure 3, the problem in this overall situation is that we have been attacking the drug itself and attempting to clean up the industry on the back end, when the manufacturers and prescribers are to blame. With the addition of restrictions, it has been shown to decrease overall prescribing of opioids in favor of ulterior methods. These methods could include access to non-opioid pain management, rehabilitation programs, assessing the patient's entire medical history, and to get to the root of the problem instead of prescribing opioid pain management. As mentioned before, the Comprehensive Addiction and Recovery Act of 2016 requires the Department of Health and Human Services to create a task force that reviews the pain management practices that are developed or adopted by federal agencies, as well as provides updates to these practices. It also states that the department must create awareness and provide education for the risk of abuse of prescription opioids. While this bill is promising in its efforts to curb addiction to opioids in the future by providing avenues of both educational opportunities as well as providing grants for research and programs that aim to help reduce opioid abuse, it does not address the direct marketing of opioids to physicians and prescriber groups. The 21st Century Cures Act focuses mostly on the funding and research towards addressing the opioid crisis. Although this law provides grants for research and development of NIH innovation projects, there are no parameters in this bill, and therefore the system could potentially be abused. The Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients and communities Act requires drug management programs for individuals that Medicare deems at risk, as well as requires Medicare to cover services provided at certified opioid treatment facilities. These requirements are only able to be enforced under Medicare Part B, which is available to Medicare prescribers for a premium. While this bill still may be worthwhile, it does not address individuals who are not eligible for Medicare or individuals who do not have health insurance. The Affordable Care Act of 2010 requires pharmaceutical companies to release prescribers' names that they have marketed towards and who have received some sort of monetary gain from them. While this adds a layer of transparency between patients and their providers, it does not limit the interaction between the pharmaceutical company and the prescriber. The Fentanyl Sanctions Act establishes programs whose aim it is to address the opioid trafficking, as well as imposing sanctions on foreign individuals and entities who are involved in these activities. This bill also addresses the trafficking of synthetic opioids and enlists the help of the Office of the Director of National Intelligence to enforce these sanctions. The aim of the Blocking Deadly Fentanyl Imports Act is to gather information about production of fentanyl in foreign countries, as well as withhold assistance from such countries who don't have emergency scheduling procedures for new and illicit drugs, as well as those who do not have any way to prosecute such offenders who are manufacturing and distributing illicit drugs and don't require tableting and encapsulating machines to be registered with their respective governments. My proposed program would include a $500 monetary limit on direct-to-physician marketing done by pharmaceutical companies, as well as pose other restrictions as seen in the difference in difference analysis done by Dr. Eisenberg and his team. These restrictions would include barring pharmaceutical representatives from medical facilities, as well as restrictions on consulting or speaking arrangements that prohibit prescribers from being paid by the pharmaceutical companies themselves, as well as a conflict of interest disclosure. I believe this is the best strategy because, in combination with laws that have already been passed, this policy would be able to get to the root of the problem, which is stopping the drugs as they come into the system versus acting retroactively. As we saw in the difference analysis, the amount of opioids prescribed decreased as the restrictions placed on marketing to physicians increased. The implementation of this new policy would take place at the start of the fiscal year and would track physician income through the payroll department they are associated with. Each physician would keep track of all talks they attend and which companies attended, as well as disclosing any other gifts received from individual companies to be turned in to their respective chief of staff. Once a physician hits their monetary limit, all further engagements that end in a gain will need to be terminated as it violates hospital policy. The significant risks could be losing opportunities for innovative new medical devices created in the biotech field of the pharmaceutical industry that sales representatives could be introducing to providers. If angered, the pharmaceutical companies may pull their money from clinical trials that were previously supported, which would severely impact research. So the key stakeholders in this policy would be the pharmaceutical companies, since they contribute to the funding of innovative research and drug development. However, with this policy, these companies can take the money that is generally allocated to direct-to-physician marketing and put it towards other projects that would improve healthcare. To gather support, the focus should be moved towards bringing an end to addiction and fighting the opioid epidemic together as a whole community. The physicians themselves would also be a stakeholder in this, as they would most likely be against this policy since it does limit their ability to communicate with the pharmaceutical industry. There would also be more surveillance into who these physicians were interacting with, which may seem like an intrusion. The way that I would sell this policy to them is through education about how drastic this situation with the opioid epidemic is, and remind them about the pharmacokinetics of these medications, including their mechanism of action on the body, and demonstrating why alternate methods of pain management may be just as effective while reducing the number of opioids circulating in the community. This could also relieve some of the pressures physicians may be experiencing from the pharmaceutical industry to push certain drugs instead of alternate therapies. Ultimately, I would approach both groups in the same manner, trying to make the patient and their healing the center focus. The opioid epidemic is a public health crisis that in 2021 was killing 220 people per day in the United States. The key to fighting this is to provide the communities with educational tools to increase the public's awareness about the dangers of misusing opioid medications, as well as placing restrictions on pharmaceutical companies' relationships with physicians. With these tools and with the relative guidance, physicians will be able to make evidence-based decisions when it comes to patient care without the outside pressures. It's important to get ahead of the opioid epidemic in any way that we can, and with imposing these restrictions on direct-to-physician marketing, there will be less outside influence on the treatment of patients, which will lead to a reduction in the amount of opioids that are prescribed and will encourage alternate therapies for pain management in the future. Way that we can.